Hi, Dr. He. Good afternoon.
Yeah, good afternoon, Dr. Tan. So I can start my presentation?
Yes, please.
Okay, first of all, good afternoon, Mr. Chairman, ladies and gentlemen. My name is Hee Hwa. I'm an international cardiologist working in Tan Tock Seng Hospital, Singapore. First of all, I'd like to thank the HSIC organizers and Elixir for inviting me to give a talk to share our preliminary experience using DynamX bioadapter DS in primary PCI. So as we all know, the primary PCI is the preferred method of reperfusion over thrombolytic because it is associated with much better short-term and long-term outcomes. And bleeding risk is much lower compared to thrombolytic. So majority of patients in primary PCI will undergo stenting. And right now, drug-eluting stent is considered the standard of care. And this has received the ESC guidelines class 1 indication. So a few studies have shown that drug-eluting stent is superior to bare metal stents because it has lower TLR rate and sometimes, in some cases, lower stent thrombosis rate. So we know that we have a lot of DES on our shelves. So is there any particular DES that can make a difference for your STEMI patients? So if you look at the most recent contemporary trial, this is the BioSTEMI trial that was conducted to compare the outcomes comparing the Osiro drug-eluting stent, which is considered third generation biodegradable polymer sirolimus eluting stent versus the Zyme stent, which is the second generation durable polymer everolimus eluting stent. So this was published in The Lancet in 2019. So in summary, when they look at the primary endpoint, target lesion failure at 12 months was much lower in the for the Osiro, and for Zyme is about 6%. And the difference is mainly driven by lower reduced ischemic driven TLR for the Osiro DES. So the Osiro DES is much thinner strut, about 60 microns for sizes below 3 mm. So they have the results at 2 years follow-up. Again, you can see that event rate increased for both DES, but it is much higher for the Zyme group at 8.1%. Again, it is mainly driven by lower rate of TLR for the Osiro stent. So despite the good results for the Osiro DES, I think we must not forget that the stent thrombosis rate can be quite high when you implant stents in primary PCI. It can range from 1 to 3%. So for the Osiro DES, the stent thrombosis rate is about 1.7% at 1 year, and it is about 2% at 2 years. And there are various predisposing factors on why this happened. So a lot of times when we do primary PCI, the vessels tend to vasoconstrict. So we may underestimate the true size and we undersize the stent. And when you implant stents in a pro-thrombotic state with a pro-inflammatory state, there may be delayed arterial healing. So these are some of the predisposing factors why there is a much higher stent thrombosis rate in primary PCI. So there is a clear need for a better stent platform for our STEMI patients. So what comes to mind would be the novel stent, the new stent, the DynamX bioadapter DS. I think the first speaker has highlighted is novel uncaging elements. But just for those people who are not familiar with the DynamX stent platform, it is a thin cobalt chromium stent, 71 microns, and it is a bioresorbable polymer, and it elutes the drug novolumens over 3 months. And you have heard from the first speaker on what are the advantages when you uncage the artery. You will restore the vessel compliance, you will restore the pulsatile motion of the artery, and in fact, you have what we call a positive adaptive remodeling. So the MSA and the MLA actually increase when you do a follow-up intracoronary imaging. So these are the conclusion from the bioadapter first in-man study that showed the advantage of the DynamX uncaging elements. But if you look carefully at the preliminary data, there is no data so far for DynamX in primary PCI. So over in Singapore, we perform about 450 to 500 primary PCIs in our center. And we were curious to know whether does this stand works in our patients with STEMI. So we did a small registry looking at the 30-day outcome for our patients. So from January to October, 20 patients in our center received DynamX bioeditor DES. And the primary endpoint for our initial registry was MACE, which is defined as a composite of all-cause mortality, reinfarction, and TRR at 30 days follow-up. So for the first 20 patients at 30 days, there was no death. In fact, there was no event, no reinfarction, TLR, and stent thrombosis. So we reported this as an abstract in the TCT-AP, which was published as a supplement. So for today's talk, I'm happy to share more. We have used DynamX in about 36 patients, and we have some data for 6 months follow-up. So up to January last year to July, we have implanted DynamX in 36 patients. Mean age is about 57, and majority are male. And we use it in inferior STEMI in majority of cases. So RCA will be the target vessel, the most common target vessel. Majority of our patients have single vessel, and a lot of them are actually quite hemodynamically stable. So cardiogenic shock is only in one patient. And we use transradial in the majority of our cases. When it comes to cardiovascular risk factors, a lot of our patients were smoking. Diabetes mellitus was present in about 14% of patients. So we use quite a bit of intracoronary imaging in our center, mainly IVUS. So in about 66% of cases, we size the artery before we implant the stent. And the patients were rather thrombotic, so we had to perform thrombosuction. And for those with large thrombus burden, we have to use the penumbra indigo system. We also use a bit of 2B3As, mainly for boluses. So now when it comes to number of stents, I think majority of patients receive one stent. The mean stent diameter is about 3.1, and total stent length is about 28.5. So I'm happy to share the results. So as you all know, the first 30 days, we have no event. And for 6 months follow-up, which is the data is available for 24 patients, again, you can see that we have no event. So we are quite pleased with the initial results. So I think the best way to showcase the technology is to show a couple of cases on how we use it in the real world. So this is a 61-year-old patient presented with anterior STEMI. You can see the prox LED is completely occluded. After we did the POBA and restore flow, you can see diffuse disease from prox to the mid-LAD. So we did IVUS, and then after that, we delivered the DynamX DES 3538. And you can see that we implanted the stent right at the ostium, and we had quite a nice final result. So this is the epicranial. The results we thought was looking very good. So for the second case, patient 67 years old presented with inferior STEMI, and you can see that after we POBA, there is a residual stenosis in the mid-RCA. Again, we perform IVUS, and then we delivered the 3538, which went down quite easily. So we implanted the stent, and that is the final result. So the patient had a bit of chest pain and was readmitted to our hospital, and we did a restudy angiogram at 7 months. And you can see that the stent was widely patent. So one thing that I like about the DynamX is actually quite visible when you do the post-dilatation, and you can see that you're able to see the edge of the stent very well, and that will help you in your post-dilatation of the stents. So I think in conclusion, ladies and gentlemen, I think our preliminary experience using DynamX in primary PCI was seems to be safe and feasible. There's no reported 30-day MACE for our 36 patients. And for the 6 months MACE, for the first 24 patients, in fact, there was no reported events. I think there are certain caveats to our results. I think we did not use the stents in patients who are very sick. And also, we do not recommend to use it in patients with very heavy calcified lesions. So I think like all new technology, we need to have more data. We need to have a longer follow-up in a larger cohort of patients to confirm our findings. And ultimately, you need a randomized control trial. Thank you very much for your kind attention.